Hello, friends. This is a I think this session is very important per se because hepatitis C has been one very emerging field. Why I'm saying emerging because before 2011, 2012, we didn't have any much drugs for treatment of hepatitis C. So though cure was possible at that time, but it was at the cost of great toxicities of the drugs which were used at that time, like interferons. After 2012, the first drug came, that is protease inhibitor, Simipravir, and then sofosbuvir, and then we have so much advancements in this field in 9 years that guidelines change every month. I would say every year, every few monthly guidelines change for the management of hepatitis C infection. So everybody knows that for this common diseases, multiple bodies give multiple guidelines. So if we are having a guideline which is based on our own nation, like primarily I'm targeting our own country because drugs that are available at other places may not be available in India. So the Indian guidelines are made based on the drugs available in our country. Obviously, within few years, we may get the other drugs, and it's very important to understand that at present, hepatitis C has been included under the national programs. So the drugs for hepatitis C, which are extremely costly, I mean, with respect to our Indian population, they are very costly. But now they are available in many centers, which are called as MTCs, Model Treatment Centers for Hepatitis C. So they are very much available. Though I would say the number of drugs available are limited, but they are sufficient for management of, I would say, majority 99% of the patients. So with that, we'll start with today's discussion. So these are the 4 guidelines which are commonly used all over the world. Obviously, for India, we have the national guidelines for diagnosis and management of viral hepatitis. Then we have WHO guidelines. It also came in 2018. So it's pretty, I would say, a bit old, like around 3 years back, these guidelines were released. Latest guideline that we have is HCV guidance provided by AASLD and IDSA, which is the prime body responsible for giving guidelines on liver diseases in USA. And we have EASL guidelines for management of hepatitis C, which was issued in 2020. So I have primarily focused on the Indian guidelines with some parts from WHO guidelines and very importantly the updates that are there from the AASLD guidelines. There are many much changes which have come up with respect to management in specific group of population and in specific scenarios where we can actually treat those patients which we initially excluded those. Like I'm just giving an example. CKD patients were traditionally excluded from management with the current therapies. But we have great update in that field also. So we'll start with some basics about hepatitis C. It won't take much time in this. It's pretty well known that it's a non-B hepatitis virus. It's a linear single-stranded positive sense enveloped virus. It's a RNA virus. It belongs to the genus Hepasivirus. I hope everybody knows Hepasivirus has only one virus, that is hepatitis C, which belongs to Flaviviridae family, and it has 6 main genotypes. So these are the main 6 genotypes. We have many more other genotypes which are sparsely distributed all over the world. We have genotype 7, we have many more genotypes available, and we have subgenotypes from 1 and for 3, where 1A, 1B, 3A, 3B, something like that. But this used to carry great importance earlier, even for the initial management of all patients. But now we have the pan-genotypic regimens available all over the world, I would say India, including all countries. So for initial management or treatment naive patients, genotype determination is not necessary, or I would say it's not required. It's required only for patients who have failed one of the therapists. That in that patient, we need to go for genotype, and then genotype-based testing and treatment is required. So just to mention that all genotypes have in general same pathogenicity, same pathologic features, and the risk of clinical progression is almost same except for genotype 3. That's why whenever we discuss management of hepatitis C, especially in decompensated cirrhotic patients or in cirrhotic patients, genotype 3 takes a separate need a separate discussion, a slightly different treatment, because it behaves a bit separately. So it's known to produce insulin resistance in diabetes mellitus, and it's known to produce more of hepatic steatosis, that is fatty liver, in biopsy specimens. So hepatitis C is actually extremely prevalent infection, and the problem with hepatitis C viruses, we don't have frequently the typical symptomatic presentations. Many a time we detect this hepatitis C on routine screening or for some non-specific thing. We are working up for the patient for like transaminitis, asymptomatic AST, ALT elevation, or something like that, and we come across NDHCV positive status, and then we further work up, and they turn out to be HCV positive. Now, so that's why I'm telling that onset of disease is usually insidious. Acute cases are typically uncommon. I'm not saying they do not occur, because HCV virus is so common. Even acute HCV can present in some patient. But in general speaking, when we talk about the HCV infection as a whole, majority of the patients are like, they directly come to us with chronic HCV infection. That too, majority of the patients are asymptomatic. They do not have any specific symptoms. They have very non-specific symptoms, or they will be very completely asymptomatic. And everybody knows, once a patient gets hepatitis C virus, the risk of chronicity is as high as 85%, as high as 85%. So this data will be varying, like it can be 40, 60, 50, 70, 80% in various population, in various scenarios. But in general, it is very high, as high as 85%. And I hope everybody knows, like especially in developed countries, this has surpassed the alcoholic liver disease as the most common cause of indication for liver transplant. Though even in developing countries like India and many other countries, it still remains one of the commonest cause of chronic liver disease, cirrhosis, and liver transplant. So that's why we think of hepatitis C virus. In patients, see, we have a CLD, a patient who has been diagnosed with CLD of unknown etiology. At that time, we want to work up for hepatitis C as one of the possible etiology. Same goes for a patient having like asymptomatic elevation of ALT and AST, a patient who is having jaundice. So any patient who is having either compensated or decompensated liver disease, or per se asymptomatic ALT-AST elevation, we have to work up for HCV, apart from doing work up for other diseases. So this is very in short about routes of transmission. We are not going to discuss this in detail, but I hope everybody knows that percutaneous remains the primary mode of transmission. Sexual, like I would say, fecal route does not have like much role here. Fecal is primarily for HAV and HEV virus. Hepatitis C is primarily parenteral routes. So percutaneous, it includes many things. I've just given example of one, two, like injection drug users, dialysis patients, patients who get repeated blood transfusions. Though spread from the blood products is exceedingly rare, but those who have received blood before, this HCV testing was not done earlier. So if they have received blood, so they are still at very high risk of getting hepatitis C virus infection. But at present, still you get some few cases which are because of blood product related, maybe because of the window period where antibody detection has been missed. Sexual transmission is important, though if you see percentage wise per se, the risk of if a pregnant female or if a male, not just pregnant, if a male patient is having HCV positive, chances of transmission to his like spouse is very, 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 very rare. But still, because HCV is so common, a significant number of patients get HCV infection by this route. In sexual, especially homosexual transmission is more important. Homosexual transmission is much, much, much more than heterosexual. And this is typically more common in HIV patients. Okay, so transmission of HCV via sexual route is more common in HIV patients. And perinatal transmission is known to occur, though overall the percentage-wise risk is less, but still, I just told because it is a very common infection, perinatal transmission is known to occur. Okay, so though it's not, I'm not telling it's a predominant source of like route of transmission, but still we have definite evidence that perinatal transmission do occur. And that's why it's been said that all patients, like all newborns who have been born to the mothers with HCV positive status should get screened at 18 months of age by anti-HCV antibodies. Okay, so and in children, and in children especially less than 12 years, one of the major route by which they get HCV infection is from their mother via perinatal transmission. Okay, so these are the high risk groups, among which who have exceedingly, there are more risk factors for getting hepatitis C virus. This is very like practical and very understandable. People who inject drug, there's IDU, injection drug users, men who have sex with men. I just told you, female sex workers, especially unprotected sex, people doing unprotected sex, people who received blood transfusion before routine testing of hepatitis C, people who needs frequent blood transfusion, such as thalassemia and dialysis patients, because there are always more chances compared to other patients. And dialysis, because machine may be used for other patients also, there are chances, because blood goes out of the body into the machine and then comes back. So there are chances of cross infections via dialysis machine. So I just told you, people living with HIV or per se any immunosuppressed states, they are at high risk of getting hepatitis C infection, and inmates of prison and other close setting as for HIV infection. Okay. Now, I just told you that clinical presentation of hepatitis C is extremely variable. The patient may be symptomatic or patient may be asymptomatic. Okay. So when I say symptomatic, they may have non-specific symptoms. Non-specific symptoms like fatigue, depression. They may have arthralgias, which are not, like, you don't think of HCV straightforward in these patients. They may have these are non-specific symptoms, and then not specific, I would say, but symptoms related to, in some patients, related to decompensated liver disease. Though they are also non-specific, but you obviously always tend to think of HCV or per se any HCV or hepatitis B infection patient having any cause or any case of CLD, chronic liver disease. So okay, so symptoms related to decompensated liver disease like jaundice, like ascites, patient may present with upper GI bleed, etc. So symptoms related to the chronic liver disease. So it's very important that so that's why it's been said that for hepatitis C, I will be discussing this part in upcoming slides, that whom should we test for hepatitis C. That's at that point we'll be discussing this important point. So asymptomatic, obviously, it could be simply asymptomatic in a way that they may have asymptomatic ALT, AST elevation. Usually they have ALT more than AST, but AST more than ALT can also be found. Then in some patients, I would say not, in some patients, they go for routine screening for like some routine health checkup or something like that, and they turn out to be anti-HCV positive. Okay, so those patients may turn out such patient may also come to you in that form, that when my report is anti-HCV positive, now what to do? Okay. Then this is very, I have explained this way in the form of symptomatic and asymptomatic, but remember that even asymptomatic patient can have an advanced form of liver disease. Okay, asymptomatic patients can also have advanced form of liver disease. So when I say liver disease with respect to HCV, initially there is inflammation, then it leads to fibrosis, which leads to cirrhosis. Now, cirrhosis can be compensated. I will discuss how to differentiate compensated and decompensated very simply in clinical scenarios. And decompensated. So decompensated, it simply means, if I put in one word, it simply means CTP, child Turcotte Pug score B or C. So any patient who is in this group is decompensated, he will always be symptomatic because of the complications of the cirrhosis. But these are the patients whom you should pick up, because these patients have, I would say, compensated cirrhosis is not just important for HCV, for any per se, any liver disease CLD. This is because if you treat, if you apply specific treatment when it is available for a particular disease, there is possibility of reversal of disease. Patient may completely go into a normal state, or at least a very much improved state. So this inflammation, fibrosis, cirrhosis is obviously best guided by biopsy. But remember, in today's world, biopsy being done for hepatitis C is completely rare, or it is almost not done. Very, very rarely it is done. So the specific indication, I would say, for doing a biopsy in a patient with HCV patient is when you are suspecting some other cause. When you're suspecting some other cause for CLD apart from HCV. I hope you are getting this. So if we are thinking of some other etiologies and we are not getting the etiology, and that time only we may work off, we may get a biopsy done, and then further treatment can be modified. But otherwise, per se, for hepatitis C, we don't do a biopsy. because we have pretty sensitive and specific markers, non-invasive markers for assessment of fibrosis and cirrhosis. They are very much validated at they are like available since 15-20 years, but now they have been like studied extensively, and they are well available and well studied, and some are very cheap. They simply require calculations, nothing else. So this is the thing I wanted to make. I wanted to clarify. For hepatitis B, you will have some specific indication of doing biopsy, but for hepatitis C, we don't need a biopsy in majority of the patients. Okay, so I wanted to discuss this. See, there are some important risk factors which are associated with accelerated fibrosis progression. Like per se, what is the most concerning thing for us? Most concerning thing for us in hepatitis C patients, obviously, it's the liver disease. A percentage of patients do have a extrahepatic manifestation. We'll be discussing after this, but the main concern for us is the liver disease. That too, patient going into cirrhosis and decompensation, and then he requires transplant. Otherwise, he dies in few years. Okay, so there are some risk factors which are associated with accelerated fibrosis progression in hepatitis C. It is specifically for HCV patients. So these are some risk factors. Some can be modified, some cannot be modified. So those who present at advanced stage of fibrosis, you cannot do much thing. Like obviously by treatment you can modify this, but otherwise you cannot modify. If they present with advanced stage, the chance of reversal are less as compared to those who present in early fibrotic stage. So same way, inflammation, more the inflammation, more the risk of fibrosis. This is very important. Older age at the time of infection or older age at presentation, this is very important. That's why I hope everybody knows there is one important score we'll be discussing, FIB-4 score for non-invasive assessment.
Sir? Ashraf, sir?
There is some issue.
Sir,
Yeah. Am I audible now? There was some connection failure.
oh, okay, sir.
Am I audible now?
Yeah, you're audible, sir, now.
Okay. Please make me host so that I can share the content.
Yeah, sir.
Sorry for this glitch when I don't know. Okay. So like we were on extrahepatic manifestation. I hope I'm audible.
Yes, sir.
Okay.
Yes, sir.
So we were on extrahepatic manifestation. Though we have all this, we need to remember cryoglobulinemia, chronic kidney disease, Sjogren's syndrome, diabetes, and depression. Though this all are also can occur. Okay. So now this is very important. Whom to test for HCV? So you can think of this in two ways, but I would say the first strategy is preferred. So testing for all, because majority of the patients are asymptomatic, so we have to think for testing for all more than 18 years. For less than 18 years in specific group, you may focus testing, you may do, but for at least testing once in 18 years. Can we take a 2 to 3 minutes break?
Yes, sir.
Yeah, sorry for that. Just 2 to 3 minutes. So yeah, so I hope I'm audible now. Okay. So it's very important now to testing for all. So on test on demand is also desirable at present in this in today's scenario, because it is so common. So one is testing for all, obviously, but at least doing a focus testing in patients in whom you suspect based on any clinical features, hepatic or extrahepatic features, you may go for anti-HCV testing and then further do the workup. But in general, if a person comes to you and he wants anti-HCV testing, that is called testing on demand, you should encourage that thing at least once in a patient more than 18 years. And in multiple times in those patients who are having risk factors for acquiring HCV, I just told you earlier, those high risk groups. Okay. Now, I hope this is very clear. This is obviously based, everything, the sentence I am using are based on the guidelines only, nothing from my own knowledge. Okay. So how to diagnose HCV infection? So you obviously have two primary tools. We have many more. Two primary tools for HCV diagnosis. First, obviously, is always going to be anti-HCV antibodies. Okay. So anti-HCV antibodies. So at present, we are using third generation immunoassays. So they are highly sensitive. They have sensitive specific of the range of 99%. So that should not be an issue in ruling out or ruling in the diagnosis in hepatitis C infection. But it's very important to remember some of the concern with the use of anti-HCV antibodies. So first is it cannot differentiate acute or chronic. So it is positive in both acute or chronic HCV infection. Okay, I hope I'm very clear about this. And secondly, in the window period in the initial acute phase of the HCV infection, that is window period of approximately 4 to 8 weeks after the introduction of the HCV virus. So during this 4 to 8 weeks, anti-HCV antibodies will be negative. After that, we get the anti-HCV antibodies. During this window period, we can straight away use HCV-RN in patients in whom we are highly suspecting hepatitis C infection. For example, if we are having confirmed, I would say confirmed exposure to a patient, a confirmed exposure to HCV, and then patient is getting hepatitis symptoms, something acute symptoms, and in whom we are suspecting hepatitis C infection. So an antibodies will come negative for first 4 to 8 weeks. So at that time, we can directly go for HCV RNA testing. It will come positive in majority of the patients. Okay. So first you have anti-HCV antibodies, and this can be done in both ways. You have enzyme immunoassays available, which takes a bit more time and can be done only in laboratories. And we have fairly equally sensitive and specific rapid test, which are frequently the kits which we use frequently in the labs also. So they take very less time as compared to enzyme immunoassay. They require less expertise, less technical expertise in that sense. So, and their sensitivity and specificity is on par with the immunoassays. Okay, so they can be based on immunochromatography, horizontal horizontal assays, vertical assays, and we have many more like particle agglutination tests. So any of the kit which has been certified and to be having enough specificity and sensitivity, we can use their antibodies. So what does anti-HCV antibody means? So if a patient who is having anti-HCV antibody positive, it means either he is having acute or he is having chronic infection. So, or third important, this is actually very important, past or I would say resolved HCV. Okay, or even third scenario, I would say treated, successfully treated. So any of this patient will be having, I would say successfully or unsuccessfully. So anti-HCV antibodies can be positive in acute HCV infection. It will be positive in chronic HCV infection. It will be positive in past resolved HCV, past treated HCV, or past unsuccessfully treated HCV. In all these patients, anti-HCV antibody can be positive. So how will you differentiate this? It is very simple and straightforward. You go for HCV RNA testing. HCV RNA, which is a marker of active, I would say active infection. So it could be acute, it could be chronic, but it's a marker of active infection. So HCV RNA will be positive only in active infections. So at present, there is no need to differentiate or no need for treatment purpose. We do not have to differentiate between acute and chronic. Both require same treatment. Because as we all know, because majority of the patients are going into chronic phase. So it's like impractical just to wait for 6 months and then diagnose chronic infection. So what is as AASLD recommended is to treat all acute HCV infection like chronic HCV infection. So any patient who is having anti-HCV antibody positive, we get reflex test. It is called as reflex testing. HCV RNA is the compulsory next step. If it comes positive, that means there is active infection. Acute or chronic doesn't matter. Okay. And then we have to treat those patients. So I will be discussing whom to treat. That's also now very, very simple. So, okay, just remember two things about HCV RNA. We have two types of assays. One is qualitative and what is quantitative. So qualitative will give you report in the form of detected, not detected. Quantitative will give you exact number. So exact number as it doesn't have much relevance in treatment, but still, because they have main concern with difference between this is their sensitivities. Sensitivity of this is 1000 units per ml. And sensitivity of this is as low as 1015 copies, not units, 15 copies. 15 copies. Okay. So this is the difference, though where quantitative, because quantitative require more technical expertise, it requires like very costly machines and setups. So in places where quantitative is not possible or not available, qualitative should suffice, because almost more than 90% of the patients always have one or more of the time copies like they have more than 1000 copies in their blood. So that should not make much difference, though you may miss some of the patient who are having less than 1000 copies, but in general almost majority of the patient will come positive by qualitative also. And I told you the exact value doesn't matter, it's just positive if it is just presence or absence which determines the treatment, determines the need for treatment. Okay, so this is like from the AASLD, very simple and straightforward. If HCV antibody is positive, so this all reflects, you have to do, there's no option, you have to do HCV RNA. If it is detected, it is current, I would say, I just told you active or current infection. Acute, chronic doesn't matter, you have to treat those patients. It is as straightforward as that. All patients with HCV RNA positive have need treatment, they need treatment, but what treatment to give, that depends on the patient stage. Okay, now if it is not detected, that simply means if HCV antibody is positive and HCV RNA is negative, the only one scenario which you can think of is patient has either been past, he got a past acute HCV infection which he got treated, I would say recovered on his own. It occurs in fairly 15 to 20% of the patient, in even more for some population and for some genotypes. Okay, but in general, if it is not detected, nothing to be done. Only that this is what is required. This additional testing is required only in patients who are having very high risk factors for HCV infection. So you may go for further testing after a few months in patients, especially in the high risk groups. Otherwise, in general population, if HCV variant is not detected, nothing to be done with respect to HCV. So this is from the WHO. This is very simple. Just I wanted to add one more thing here, that at many places, even the qualitative test for HCV RNA are not available. So nowadays we have one more test which is equivalent to HCV RNA, and it does not require so much expertise. But though it's a relatively new thing, relatively nothing very new. This wasn't used earlier. This is called as P22 core antigen, HCV P22 core antigen. So if antigen is positive, it is equivalent to HCV RNA. Remember, it's much less sensitive as compared to HCV RNA. But if it is positive, it is like very straightforward. HCV RNA is going to be positive in those patients. So if HCV RNA is not available, which is nowadays very rare, almost it's very fairly available everywhere. But if it is not available, but HCV antigen is available in those patients, you can go for HCV. You can consider that patient as HCV having HCV RNA positive equivalent, and you will have to treat the patient. Okay, so the core antigen value is more for diagnosis, for ruling
Sir, you aren't audible.
Sorry for the inconvenience caused. Sir has some network issues. He'll be joining us right back.
Yeah, am I audible now?
Yes, sir, you're audible.
So, like, how much was missed? Even I didn't get to know. Please make me host.
Yes, sir, just a second.
Yes. Can anybody tell me from where this became like there was a technical glitch? Please let me know from which part. Yes. Can anybody let me know from which part like there was miscommunication? Okay, okay. So like fairly much thing. Okay. So yes, am I audible now? Okay. So like what I got to know is from this part it's left. So I just discussed earlier that we have anti-HCV antibodies and HCV RNA for testing of hepatitis C infection. I just told you how do we approach the patient who is having anti-HCV positive infection. Now, in some places where HCV RNAs are not available, both qualitative and quantitative methods are not available. We have one more modality which is available that is called as HCV.
Sir, you aren't audible.
Am I audible?
Yes, sir, you're audible now.
What is happening? Like, I don't know. You have to again make me a co-host.
Sir, you are the host.
Okay. Not.
Just a second, sir.
Yeah.
Yes, sir, you're the co-host, sir.
Okay. So am I audible?
Yes, sir, you're audible.
So we'll start again. Please let me know. Like I don't know how you will let me know. Just like leave a reply on the YouTube live channel if there is some technical glitch in between, that I can know.
Yes, sir.
Okay. Okay. So I hope I'm audible now. So we are like I'll be starting again with the HCV core antigen. So I just discussed with you that when any patient who is having anti-HCV antibody positive, we have to reflex testing. That is, next step has to be HCV RNA. If it comes detected, you have to treat the patient, and if it is not detected, if HCV RNA is not detected, you don't need to treat the patient. Okay. At places where HCV RNA is not available, so both qualitative and quantitative methods are not available at those places. If core antigen, that is HCV P22 core antigen, if that is available, you can consider it as an equivalent of HCV RNA. And if its core antigen is positive, you consider it to be equivalent to HCV RNA and treat the patient. If it is negative, you consider it to be HCV RNA negative equivalent. But remember, this P22 core antigen is having less sensitivity as compared to HCV RNA, but specificity is fairly good. So if it's positive, it's going to be active infection. If it is negative, in those scenario, you may have to further do workup by doing HCV RNA. Okay. Now coming on to this concept of compensated versus decompensated cirrhosis. So this is true for any liver disease, any chronic liver disease, not just for, I would say, not just for hepatitis C, but it's important for any liver disease. But for hepatitis C, it's very, very important to differentiate this patient, non-cirrhotic versus compensated cirrhotic versus decompensated cirrhotic patients. So how do we assess this? I just told you earlier that cirrhosis is best diagnosed by liver biopsy, but liver biopsy is having its own disadvantages. At present, for hepatitis C, liver biopsy not used for assessment of fibrosis or cirrhosis. What we use is non-invasive methods. We'll be discussing the methods available or routinely used for HCV for non-invasively assessing cirrhosis. So if patient is having cirrhosis by non-invasive methods and he's not having any signs of decompensation, what are the signs of decompensation symptoms? Varicose bleed, encephalopathy, ascites, and jaundice. If nothing is there, those patients you can label as I would say compensated cirrhotic patients. And if by non-invasive methods there is no cirrhosis, it's obviously going to be a non-cirrhotic patient. But say a patient who is having cirrhosis by non-invasive methods and he's having clinical or lab evidence of decompensation, say like I just told this, we use this CTP score, Child-Turcotte-Pugh score, for assessing the severity of cirrhosis. So if it is class A, that is 5 to 6 points, we give 1, 2, 3 for each of the 5 points: encephalopathy, ascites, bilirubin levels, albumin, and PTI, that is coagulopathy. For these 5 things, based on this, we get a score. If it is between 5 to 6, that means patient is having compensated cirrhosis. If there is some clinical or lab evidence of decompensation, I just discussed earlier. So objectively, you put it as CTP B and C. So any patient who is CTP B or C, he is said to have decompensated liver disease, and all others are compensated liver disease. Okay. So how do you assess or non-invasively cirrhosis and fibrosis? So before that, I just want to discuss this thing. This is, I hope you all know, this is the age-old METAVIR staging. Nowadays, we have more staging which have available for assessment of fibrosis, like Ishak staging, but still METAVIR can be still used. It has been used since many decades. So it's basically histological assessment of severity of fibrosis. METAVIR staging is basically histological assessment of liver fibrosis. Stage 0 means no fibrosis. Stage 1 means only portal region fibrosis, only portal fibrosis. This is portal fibrosis plus septa formation. So then you have multiple septas. And finally, you have cirrhosis. So stage 4 fibrosis is cirrhosis. So what stage 0 and 1 are considered to be as insignificant fibrosis. 0 is obviously no fibrosis. Stage 1 is insignificant fibrosis. So anything, this is basically called as F0, F1, F2, F3, and F4. Okay, so anything more than equal to F2 is considered as significant fibrosis. Anything more than equal to F3 is considered as advanced fibrosis. And obviously F4 is cirrhosis. Okay, I hope this is very clear. So how do we, this is the obviously invasive method which we don't use frequently nowadays for hepatitis C, but non-invasive assessment of cirrhosis and fibrosis is basically by this frequently used, I would say, this EPRI score, FIB4 score, and the transient elastography, this FibroScan. Fibro test is still not very commonly used. So this is a very simple. You have the AST, you have the platelet count. In FIB4 score require 4 things: AST, ALT, age, and platelet count. Based on these 4 values, you decide, you get this score, and in specific cutoff are used for diagnosing or for ruling out cirrhosis or significant fibrosis. Okay, so and this fibro test is done in only specific laboratories available at very less places, so not very commonly used. But still, if it is available, you can definitely use it. So it is based on like 5 to 6 parameters. I would say apart from age and sex, you use the various lab parameters like GGT, you use alpha 2 macroglobulin, we use bilirubin, total bilirubin. Then what else is alpha 2 macroglobulin, GGT, total bilirubin is used, you have haptoglobin, and apolipoprotein A1. And there is a modification of fibro test which also adds ALT. So basically based on these things, based on the age, sex, and all these 5 or 6 parameters, we get a specific score, we have a specific formula, and then we give a cutoff scheme. If it is above this, we consider to be having significant fibrosis or cirrhosis. Okay, but not very frequently used. We'll be discussing slightly more about EPRI FIB4 score. Okay, so I hope this is this very simple formula of EPRI. We should know at least the formula. That is AST level of the patient divided by AST level upper limit of normal, which is like, it is variable 30 or 40 for various labs. Okay, and divided by platelet count. So this platelet count has to be in these terms, 150 to 450. This is the normal cutoff. In this way, it is 10:9 per liter, not that we use routinely per cubic millimeter. Okay, in this, I would say in this units, we have to put the platelet count and we get a score. Now, what is the significant score? Like, let me, I just said one thing before. Today, what is something called a significant fibrosis, there's something called a cirrhosis. So if you are using EPRI score for diagnosing significant fibrosis, so less than 0.5, it rules out significant fibrosis. Okay, more than 1.5 rules in significant fibrosis. Okay, so I hope you all know what is significant fibrosis. It is basically more than equal to F2 stage. And if it is less than 1, it rules out cirrhosis. If it is more than 2, it means it rules in cirrhosis. So you can use this EPRI score, which is fairly validated for hepatitis C virus, in this disease. So you can use this cutoff. This is something called as low cutoffs. This is something called as high cutoff. So remember, this scores, they are more of used for ruling out than for ruling in. But still, they are very, very useful for both. Okay, whenever you doubt, you may get one more. That is, you can get transient elastography or the FibroScan done in those patients, and if both match, if there is no discrepancy, you will say for example, if both are showing fibrosis or both are not showing fibrosis, you can consider that patient as having or not having fibrosis. This FIB4 score is based on this age, AST levels, platelet count, and ALT levels. And here it is very simple. If it is less than 1.5, it is significant fibrosis. If it is more than 3.25, it is significant fibrosis ruled out. And if it is more than 3.5, there is significant fibrosis. Okay, and in between this, it is indeterminate. Definitely, you cannot say in. So these are the patients where you get indeterminate scores, where you need to do a second test, that is FibroScan, to assess for non-invasively assessment of fibrosis. Okay, the fibro test I just told you, it is based on this 6 or 7 parameters, 7 or 8 parameters: age, sex, GGT, alpha to microglobulin, total bilirubin, apolipoprotein A1, and all those things we use and we get a score. Now, coming to FibroScan, it is a modified. You have a special. It's not simply modified ultrasound. It's a special machine which uses ultrasound waves for non-invasively assessing the liver stiffness. So the unit is usually kilopascal. Okay, it is assessing the liver stiffness in terms of kilopascal. So even here also we have variable values, but just remember one: more than 12.5 is considered for HCV. For HCV, it is considered that the patient is having cirrhosis, and more than 7.1 having significant fibrosis. So any patient who is having value of less than 7.1, you can say that there is no significant fibrosis or cirrhosis. If it is more than 12.5, you can definitely say that patient is having cirrhosis. If it is 7.1 to 2.5, you can say at least patient is having significant fibrosis. Though these cutoffs vary, because whenever you want to increase the specificity or sensitivity, you may vary this value based on different studies. But in general, more than 12.5 kilopascal is cirrhosis, more than 7.1 kilopascal is significant fibrosis. Okay, I hope this is now very clear. So these are the high and low cutoffs for FIB4. Okay, so this is just for showing you that we have different sensitivity and specificity at various cutoffs. Okay, this is from the WHO guidelines. Okay, now coming on to the main part of today, that is the drugs used for treatment of hepatitis C infection. Please, those who have not, like, the main things with respect to the management of HCV will start from here. Now, I hope you all know that before 2012, we had very few drugs available in the form of pegylated interferon alpha, and ribavirin. Nowadays, they are not considered as the first-line agents for management. Though ribavirin is definitely used in some specific scenarios, but these three groups form the mainstay of management. And remember, one drug treatment is not recommended for hepatitis C infection because of a risk of resistance and treatment failure. Okay, so I will be first discussing the drugs which are available in India. There will be some drugs which are not available in India, which are and which have to be used if they are available. And there are some drugs which have become obsolete now, which are not used in general. Okay, so first, drugs which are available in India, I will mark it as I. Okay, so obviously ribavirin is available and we use. Valpetasvir is definitely available in India. Sofosbuvir is available. Decletasvir is definitely available in India. And you have only 1, 2, 3, and 4 ribavirin. 4 drugs are available for management of cirrhosis, liver disease because of HCV in India. Okay, so these are the main 4 drugs available. Otherwise, if I go as a general guideline with respect to ASLD or EASL guidelines or WHO guidelines, what drugs are at present used or can be used? So they are basically this: glycaprevir, voxilaprevir, pimrentasvir, ledipasvir in specific situations only, and ribavirin, obviously, apart from sofosbuvir. So rest all drugs, I will say disabuvir, interferon alpha, grezopavir, simiprevir, tilaprevir, boceprevir, even peritaprevir, elbasvir, ombitasvir. These drugs are almost very rarely available. They are not almost required now. So they are almost out of the guidelines. Though it's there because they are specific for one genotypes, and as we have pan-genotype drugs available, so no need of these drugs. Nobody is producing these drugs. Okay, I hope I'm very clear. So out of this, what you should remember, out of this protease inhibitor, NS3/4A inhibitors, 1, 2, 3. In the NS5A polymerase inhibitors, 1 and 2 and 3. And ledipasvir in some situation it is used even today also. And NS5B only 1, that is this drug, sofosbuvir. And ribavirin is specifically used in some situations. So I hope I'm making some sense here. Okay, so I hope for those who have never been exposed to these drugs, it will be a bit difficult to digest these things, but still you have to remember this thing. At least the drugs that I have numbered, those remembered at least those drugs. And out of those, at least you have to remember those which are available in India. It is Velpatasvir, Sofosbuvir, Decletasphere, and Ribavirin. Okay? I hope I am very clear. So remember, I just told you earlier that single drug therapy is of no use. You always have to use combination agent. It's just like hepatitis C infection, HIV infection. You cannot use a single drug because of risk of failure of treatment, and more importantly, risk of development of resistance. Okay. So what regimens are recommended or what regimens are approved? So at present, we want to use pan-genotypic, DAA, something called as pan-genotype, direct acting antiviral drugs. So first is Sofosbuvir. So obviously I'm just naming those. Some will be used in non-cirrhotic, some cannot be used in cirrhotic, some cannot, something like that. Difference remains. But I'm just discussing all the approved, FDA approved drugs or European Medical Agency approved drugs which are being used today in India or all over the world. So first will be Sofosbuvir plus Velpatasvir. So this is the pan-genotypic regimen. Second is Sofosbuvir plus Decletasphere. Remember, Decletasphere is a generic drug at many places over the world. So its use has been gone down in developed countries like USA and Europe, some European countries. But still, for India, it's not like it is not efficacious. It's also pan-genotypically effective for all genotypes, and it's relatively cheaper. I would say relatively cheaper than other drugs. So second is this. Third is very important group, Glycapervir plus Pembrolizumab. Okay. Then, so these are the three main. Other are Sofosbuvir plus Velpatasvir plus Voxilaprevir. So this is one of the typical regimen which is used for treatment failure. So when many of the drugs have failed, in those patients you use this regimen. Okay. Then in some specific situations, you may need to use Sofosbuvir plus Ledipasvir. Occasionally, now it is almost not required in any situations. Sofosbuvir plus Ribavirin. Okay. This was required 2-3 years back because this was the only drugs available in adolescents. But now we have commonly this Velpatasvir group and Pembrolizumab one, which have been approved for children and adolescents also. Okay, so if you go through the WHO and Indian guidelines of 2018, you will see that in adolescents and adults, you don't have these drugs approved. And same goes for CKD. But now we have studies available in children, in adolescents, in CKD patients. You can use this regimens. Okay. So I hope this is very, very clear. Now, let's move on to the next thing. The thing is, why to treat HCV if it is asymptomatic? Okay, many will question why to treat HCV if it is asymptomatic. So remember, it remains asymptomatic for some years. It's variable from person to person, and then patient may have liver-related symptoms and signs, and patients progress to fibrosis, cirrhosis, and then decompensation, and even HCC definitely, and leading to death. So why we want to treat HCV? Treat all HCV patients. This is the dictum. Why? Because cure is the endpoint. Because cure is possible in majority of the patient at present. Okay. So with the drugs available today, we can cure majority of the patient. Cure means it is permanent treatment for majority of the patient. For hepatitis B and HIV patient, we don't have a cure. We can just suppress their application. Okay. But cure is the target in HCV infection. Okay. So our goal of therapy is to cure HCV infection in order to prevent complication, improve quality of life, and importantly, to some extent, prevent onward transmission. So obviously drugs are very costly, but when you see in long term, it will be economical. Okay, that's why they have been included in the guidelines. Now, this term many would have heard, that is SVR, something called used only in hepatitis C virus, sustained virological response. This is a very standard definition for it. Mostly we use SVR 12, that is 12 response. It's for 12 weeks. So what we do, we treat for finite duration, that is mostly it is 12-week treatment. So we have baseline HCV RNA, which is going to be positive before treatment. That's why we are treating the patient. So 12-week treatment, then after 12 weeks of the completion, after 12 weeks of completion, what you do is you again repeat the HCV RNA. If it is not detected, that means patient is cured. The patient is called to considered to have having when I would say get SVR 12. He has achieved SVR 12. It is a sustained biological response at the end of 12 weeks. It's not 12 weeks of treatment. It is 12 weeks after the completion of treatment. So it will be 24 weeks from the start of treatment. So regimens vary. Say for some it is 24 weeks, for some 16 weeks, for some it is 8 weeks. But this 12 weeks after completion is going to be fixed. Okay, duration of treatment may vary. Okay, so I hope this is very clear. SVR 12 you have to understand. Now, coming on to the main thing, treatment of hepatitis C. So we'll discuss this in these forms: non-cirrhotic patients, then you have cirrhotic, compensated, and you have decompensated cirrhotic, and then spatial situations. Okay, friends. So I just told you earlier, at present, we don't require genotype testing for treatment naive patients. We give pan-genotypic regimens for those patients. So we'll be discussing primarily the Indian scenario or Indian guidelines because we don't have all drugs available. We'll just brief you about the other drugs which are used as per the ASLD, WHO, and other guidelines. But Indian scenario, we have to obviously, we are having very few drugs. We have to manage with those drugs. So our guidelines are based on those limited availability of drugs. So this is very, very simple. Once you have confirmed HCV infection, current or active HCV infection by detectable HCV RNA, then you go for baseline investigations, CBC, LFT, and all those things, KFT. Apart from those required, you have to look for EPRI score, 5-4 score, elastography if available. And based on that, there is nowhere biopsy here. Okay, you determine the patient is having cirrhosis or not having cirrhosis. If patient does not have cirrhosis, it is very simple. You simply treat the patient for 12 weeks with sofosbuvir plus daclitasphere. Sofosbuvir is 400 mg and daclitasphere is 60 mg OD. So both combination is available at some places it is separate, but it is single OD. For 12 weeks, it is 84 days. And after 12 weeks of completion of treatment, it is for SVR 12, HCV, and if it is not detected, treatment is completed. Okay. So please remember, I am discussing the Indian scenario. For I would say for American scenario, it will be a bit different because they don't use daclitasphere there. Remember, they don't use daclitasphere. For them, they have different drugs. For them, it is sofosbuvir, valpetasvir, or it is glycaprevir, pembrolizumab. We'll discuss that afterwards. Okay. So if patient is having cirrhosis, I just told you compensated, that is child pug A, CTP-A. Those patients should be treated with sofosbuvir and valpetasvir. Have you seen anywhere genotypic determination? No. Genotype determination is not required because these drugs are effective for all genotype in general. Though if you see the American guidelines, there are some modifications. I will discuss that afterwards. for compensated cirrhotic patients, because sofosbuvir valproatasvir is not effective against one particular genotype. So if it is possible in compensated cirrhotic patient, you have to look for genotype testing and further management. But the thing is, we don't have those drugs to be used for those patients in which that resistance will be coming positive. So we are not encouraging that thing. So it's simply for all compensated cirrhotic patients, it is sofosbuvir 400 mg OD and velpatasvir 100 mg OD. It is also FDC, fixed dose combination. And same, repeat HCV RNA after 12 weeks of treatment. So if it is not detected, treatment is completed. For those who fail this treatment, either decletasvir based or velpatasvir based treatment, which is only in few percentage, I would say 1 to 2% of the cases, you have to refer for advanced investigations like genotype testing, like resistance associated substitution testing, RAS, and further management is guided by genotype. Okay. Now, so I hope this is very, very clear. So simply making it simply, non-cirrhotic patients, you use sofosbuvir plus decletasvir for 12 weeks. So dose is 400 mg plus this is 60 mg. And if it is compensated cirrhotics, it is going to be sofosbuvir plus velpatasvir. It is 400 plus 100 mg OD for 12 weeks, same. Okay. So I am making sense, and this is very simple. So this is the summary, I would say. Patients without cirrhosis, that is uncomplicated, sofosbuvir plus decletasvir for 12 weeks. Patients with cirrhosis, that is compensated, sofosbuvir plus velpatasvir for 12 weeks. We'll discuss this separately. Okay. So I hope this is very clear. Uncomplicated, I would say non-cirrhotic and compensated cirrhotic patients. Okay. So this is the dose. We'll discuss ribavirin afterwards. Okay. Now, what this is basically, what is the WHO guidelines? WHO guideline has recommended decletasvir without any doubt. But if you see the AASLD and EASL guidelines, they do not have decletasvir in their guidelines. It is predominantly either this or this. So for those without cirrhosis, it is glycaprevir pembrolizumab for 8 weeks and sofosbuvir velpatasvir for 12 weeks for treatment naive patients. Okay, so this is obviously keep it aside currently. Okay, so glycaprevir pembrolizumab, it is also pangenotypic regimen for 8 weeks without cirrhosis, and sofosbuvir velpatasvir for 12 weeks. This is the option definitely there which we use in India, and this is for compensated cirrhotics. Glycaprevir pembrolizumab for 12 weeks. So this sofosbuvir velpatasvir for 12 weeks. This is an addition, one more in WHO. And remember, in India, as we don't, and as genotype 3 is fairly common, it is fairly common. So we don't go for decletasvir, we straight away go for sofosbuvir velpatasvir for compensated cirrhotic patients. Though these are the options available. So if genotype 3 is prevalent, you can use this for 24 weeks. Now, thing is, when somebody is making a guideline, they have to also look for the feasibility and acceptance. So 24 weeks is a little bit less acceptable for the patients, and genotype 3 being very common, I would say the commonest genotype in many places of India. Okay, after 2, followed by 2. So remember, where genotype 3 is very rare, you can use sofosbuvir decletasvir for 12 weeks even for compensated cirrhotics. But I just told guidelines are uniform, so they make very simple guidelines. For non-cirrhotic, it is sofosbuvir decletasvir. For cirrhotic, compensated cirrhotics, it is sofosbuvir velpatasvir. So I hope I am very clear. Okay, friends. So I hope I am very clear in this. Now coming on to the contraindication of direct acting antivirals. Okay. So as such speaking, there is no specific contraindication measure except in 1 to 2 situations. So sofosbuvir based regimens are contraindicated with amiodarone. sofosbuvir, especially sofosbuvir velpatasvir with respect to India. This amiodarone, if patient is taking amiodarone, you cannot give this sofosbuvir velpatasvir. Okay. Second thing, none of the DAAs have been yet studied, though 1-2 studies are being going on, but as per the guideline, in pregnancy, not indicated. Okay. So lactation is doubtful. In general, you may avoid, but if it is required, you may give, or you may wait for the lactation period to complete to stop. Then third is patient is taking potent inducers or hepatic enzyme inducers like carbamazepine, phenytoin, etc. In those patients, you may either want to change this anti-epileptic drugs, or you may have to modify some things. So there are many drug-drug interactions for some specific drugs, which is not like we're going to discuss every drug-drug interaction currently, but these are the 3 important contraindications. And fourth, children less than 3 years. None of the drugs. This was earlier 12 years. Now it has become 3 years. No drugs have been approved for use in children less than 3 years. Okay. So you have to wait till the age of 3 years and then you can treat. Only with this specific regimens approved for children, use in children. So I hope I am very clear here. Now, I was like talking about this resistant associated substitution. It is RAS. Though we have many RAS for many different drugs, but the main single most important we have to remember is this NS5A. I hope that group is sofosbuvir based drugs, and the specific mutation is Y93H. So this is for sofosbuvir based regimen, and to be done, if at all it is available and you want to modify treatment, it is to be done only for genotype 3, because it is found in genotype 3, and that too only for compensated cirrhotic patient. If you are considering this sofosbuvir plus velpatasvir based regimen. So okay, I hope I am very clear here. So there are so many other RAS, but single most important which we have to and everybody has to remember is NS5A Y93H mutation. If you find this mutation, that means sofosbuvir velpatasvir is not going to be effective in those patients. This is obviously found only mainly in genotype 3, that too in cirrhotic patients. So I hope I'm very, very clear here. Now, discuss something very important now. Treatment of hepatitis C in specific situations. So for children, I just told you, less than 3 years, no drugs. 3 to 12 years, you have only 2 drug group of approved. Sofosbuvir plus velpatasvir, and so glycaprevir plus pimrentasvir. Dose, it's basically 300 mg. This is not children. This is the adult dose. No, it is discussed here obviously because it's not available in India. But still, for 3 to 12 years, you have this 2 group of agent approved for use. Sofosbuvir plus velpatasvir and glycaprevir plus pimrentasvir. Okay, for 12 to 17 years, that is adolescents. Earlier, when these drugs were not approved, we have some different agents. Okay, just a minute. For adolescents. At present, what we should use and what we use is sofosbuvir plus velpatasvir or glycaprevir plus pimrentasvir. Okay. Earlier, when this were not approved before 2 to 3 years, what other options are there if both are not available? Some and other are available. So it was genotype based. For 12 to 17 years, if it is genotype 1, 4, 5, 6, we use sofosbuvir plus ledipasvir for 12 weeks. And for genotype 2, sofosbuvir plus ribavirin for 12 weeks. for genotype 3, sofosbuvir plus ribavirin for 24 weeks. But I think if we have sofosbuvir plus velpatasvir, we no need to go for this. As such, ledipasvir is not easily available in India. Okay, I hope I'm very clear here. Okay. So again, for children and adolescents, for less than 3 years, none of the drugs have been approved. For 3 to 12 years, we have these 2 drugs, these 2 regimens. So sofosbuvir plus velpatasvir for 12 weeks and gliclapivir plus pembrolizumab for 12 weeks. Both are pangenotypic. For adolescents, you have sofosbuvir plus velpatasvir and gliclapivir plus pembrolizumab. Obviously, you have to modify based on the weight, but not discussing that in detail currently. 12 to 17 years earlier, when we didn't have these drugs approved, what we used to use were for less than 12 years, it was like wait till 12 years. This was the dictum 3 years back. Wait till 12 years, then only you can use these drugs. But now it is not like that. After 3 years, you can use with the approved regimens. So genotype 1, 4, 5, 6, it is sofosbuvir plus ledipasvir for 12 weeks. For genotype 2, sofosbuvir plus ribavirin for 12 weeks. For 3, sofosbuvir plus ribavirin for 24 weeks. This is for adolescents. Okay. Now, what is the main concern for decompensated liver disease? Remember one important statement. Protease inhibitor are contraindicated. Okay, just as everybody knows earlier, interferons were contraindicated in decompensated liver disease. Same way, protease inhibitors are known to produce toxicity in patients with decompensated liver disease. So protease inhibitors like it is Previr, gliclapivir, voxilaprevir, these drugs, Cimeprevir. So basically, all Previr drugs are contraindicated in case of decompensated liver disease. So what main option we have in India is obviously we have sofosbuvir, we have velpatasvir. So in decompensated, I just told you that we don't use daclitaspir is frequently in compensated cirrhotics. So why will we use in decompensated disease? So for decompensated liver disease, we use only sofosbuvir velpatasvir in India. Regimen varies for genotypes, but you have to always add ribavirin. Okay, this is the main difference. So use sofosbuvir plus velpatasvir along with ribavirin. So I hope this is very, very clear. I showed you this earlier. So for decompensated cirrhosis, sofosbuvir plus velpatasvir plus ribavirin. Okay. Now that has to be used for 12 weeks. If patient is ribavirin intolerant, I will let you know what are the contraindications of ribavirin. In those patients, you may have to use this same regimen without ribavirin for 24 weeks, double duration. Okay. And can you see this, the dose of ribavirin? The routine dose of ribavirin is less than 75 kg, you use 1000 mg per day. It is more than equal to 75 kg, use 200 mg per day. Okay. But in patients who are having decompensated liver disease, in those patients, you have to be very careful because it is known to produce more toxicity in those patients. You start at 600 mg, gradually increase to the target dose. Okay, remember that's why it's been written this 600 to 1200 mg. Okay, so if patients are intolerant, so if after starting treatment, patient has developed some side effects which are intolerable or not acceptable, or if there are some absolute contraindication, the one single most important somebody asks you, it is pregnancy. It is known to be teratogenic. Rather, it's been said that if ribavirin is used, pregnancy is contraindicated for next 6 months. So till the use of ribavirin, even next 6 months, pregnancy should not be like it. You should take care that pregnancy is not being there. So contraception is compulsory. during the period, use ribavirin in the women of reproductive age group. Same way, breastfeeding. So any severe concurrent medical disease like uncontrolled heart failure, uncontrolled coronary artery disease, COPDs, and severe infection. Active severe infections, active CAD or uncontrolled cardiac failure, uncontrolled COPD are contraindications for ribavirin. And previous ribavirin hypersensitivity, that is very practical and logical. So this is of no, because we don't use diadenosine, we don't use, to know to discuss. Now coming on to this. This is only related to contraindication. Why? Because I hope you all know the main concern or the main ADR of ribavirin is bone marrow suppression. So patient who's having severe anemia, that cutoff varies from patient to patient, and in some patients, if we have a fall of more than 2, and that in those patients you have to stop ribavirin. But at onset, if HB is very low, these cutoffs will vary individually. But if patient is already having low HB, low neutrophil count, low platelet count, and I hope you all know, ribavirin is needs dose modification in CKD. Okay, so creatine more than 1.5, you have to be more vigilant for the ADRs. Okay, this is the I just told you, significant coronary artery disease. If patient is very stable on drugs, you may still consider using it, but those who are not stable on the drugs and having active coronary artery disease in any forms, you want to avoid ribavirin. Okay, and this is because obviously already their bone marrow is not much functional normally. So if you use ribavirin, it will be exacerbating anemia in hemoglobinopathies. So I hope I am very clear here. So in one word, for patients who are having decompensated liver disease, sofosbuvir plus velpatasvir plus ribavirin for 12 weeks. If this cannot be used, you increase the duration to 24 weeks. Okay, friends, I hope this is very clear. I just told you this. Remember this protease inhibitor, that is the Previs. Only approved and used Previs are Glycaprevir and Voxilaprevir. These 2 drugs are currently used from this group. These are main drugs for pan-genotypic agents. But if you have decompensated liver disease, you cannot use this. Okay. Still, you have one more option if it is available of using other drugs like sofosbuvir plus ledipasvir and other drugs, but not the Previs in specific situations. Now coming on to this important thing, if you see the guidelines of 2018 of WHO Indian, it says that CKD patients are not eligible for DA treatment in general, but at present, sofosbuvir, velpatasvir, Glycaprevir, pembrolizumab, and even to some extent sofosbuvir, dexlansoprazole, all have been found safe with no dose modification. Okay, no dose modification. Remember, no dose modification. Okay, this is very simple. Now coming to HBV HCV co-infection. So in patients having HBV and HCV is the main driver. Okay, and so always HCV treatment takes priority. That doesn't mean we ignore HBV. So it's simple. If patient requires HBV treatment, based on these, I hope you all know HBV treatment. Their HBV patients all are not treated. Only some specific patients are treated. So if HBV treatment is required, you start both simultaneously. But if patient is not eligible for, or he does not require HBV treatment, what you do is treatment not required. And if patient is HBsAg positive, because there are high chance of HBV infection to get flared up, during HCV treatment. So for 12 weeks of treatment of HCV plus more 12 weeks, total 24 weeks, you use the HBV drugs like tenofovir or entecavir for this 24 weeks. Then you can stop if there is no requirement of treatment of HBV. So I hope you understand, during the time period of HCV, treatment of HCV for 12 weeks, and 12 weeks after that, 24 weeks, you start the patient on tenofovir or entecavir. Then you can stop. Okay. Now coming on to pregnancy and lactation, I just told you no drugs are approved for use. As simple as that. For lactation, it is still doubtful. You may want to avoid drugs. This new, their drugs are new. Okay, but once we get the data for pregnancy, then maybe we may get some new drugs in future. Now, TB, HCV co-infection. Now, what is the concern with this co-infection? Only one concern is because TB has rifampicin, and this is a very known potent enzyme inducer, and that's why HCV treatment you should avoid in those patients initially. So what is recommended is you start TB treatment. Once TB treatment is completed, then you treat for HCV. During that time, you monitor the patients. Okay. Now, last thing is treatment experienced patients. Those who are not treatment naive, basically who have taken treatment earlier for HCV. There are multiple possibilities, but in India, either they may have taken interferon, or they may have taken ribavirin, or they may have taken sofosbuvir with ribavirin, something like that. Okay. Second possibility is they have taken sofosbuvir plus daclitasphere or ledipasvir, and they have failed. So these two scenarios are possible. What to do? It is very simple. Don't get confused here. This is same. So I just told you, treatment experienced patients you have to get a genotype, because genotype 3 is notorious for some treatment failures. Now, if patient has, we'll discuss on this only. If patient has taken interferon plus ribavirin or sofosbuvir plus ribavirin, if patient is having not having any cirrhosis, simply you will use sofosbuvir plus velpatasvir for 12 weeks. No difference, irrespective of genotype. But if patient is having compensated cirrhosis, you may have to do a genotype, and for genotype 3, you have to add ribavirin for 12 weeks, apart from sofosbuvir velpatasvir. Okay, I hope I am very clear. Okay, but for patients who have failed sofosbuvir plus daclitasphere, sofosbuvir plus ledipasvir regimen, so it's very simple. Irrespective of genotype, irrespective of cirrhosis, you have to treat with this. All things are same. You treat with sofosbuvir plus velpatasvir plus ribavirin for 24 weeks. So very simple. Okay. So if a patient already who has taken interferon plus ribavirin and he has failed, or patient who has taken sofosbuvir ribavirin and he has failed, in those patients, if there is no cirrhosis, simply go for sofosbuvir velpatasvir for 12 weeks. If there is compensated cirrhosis, you go for genotype testing. If it is genotype 3, you add ribavirin for 12 weeks. Okay. But if patient has failed the treatment with sofosbuvir plus daclitasphere, which is possible in few percentage of cases, irrespective of cirrhosis, irrespective of genotype, you give same treatment. Sofosbuvir plus velpatasvir plus ribavirin for 24 weeks. And if this also fails, then obviously patient, you have to consider other special drugs, like especially one specific drugs approved for patient who have failed to sofosbuvir velpatasvir is sofosbuvir plus velpatasvir plus voxilaprevir. This is specifically studied and approved for use in this group of agents. We have other drugs also, but this is one of the main agent. Okay. Now, lastly, I have already told this actually, acute HCV infection to be treated as chronic HCV infection. But obviously here some may argue that the cost of HCV treatment is, say, I would say around 50 to 60,000 in India. And you may want to wait for 5 to 6 months and prove it to be chronic and then treat. Like, it's very individual thing, but in general, AASLD suggests that this economic constraints are not there. But that's why they recommended all patients, irrespective of acute or chronic, should be treated as same. Okay, so I hope I'm very much clear. So this was all about today's HCV discussion.